Ready when you are, Mukesh.
Yeah, right. Thanks everyone for tuning in today. So we're November's APAC Scientific Forum. So we've got quite a packed agenda for today. We're going to start off with Christine sharing about the medicinal cannabis study, giving us an overview there. And then we'll hand over to Chungsoo to give us a high-level update on the data quality of OHDSI APAC study. And towards the end, we go towards a bit of the logistics for the December meeting preview and also on the support area follow-up survey as well. Right, let's move on. Okay, so Christine, over to you to share with us more study. Thanks.
Hi guys, it's Christine from Australia, Dr. Christine Hallinan. I'm an epidemiologist and biostatistician with a clinical background. And I'm literally just going to present to you a one-slider with a graph. And it's a presentation I delivered to the Wonka conference last week. And it's an international primary care conference. And this one slide actually shows you the problem we have with medicinal cannabis prescribing and difficulties with pharmacovigilance, and a great opportunity for the OMOP community to actually contribute to the evidence base regarding detecting signals of adverse events and trying to ascertain effect of medicinal cannabis. And it's a therapeutic that is generally not registered. It's not considered a true therapeutic, but community are accessing it. So we'll just go through this one slide. I work with Yvonne Bonomo, who's a professor at the Department of Addiction Medicine in Melbourne, and I work in the HABIT team with my colleague Roger. So let's go to the next slide. This is 5 minutes. It's just 5 minutes only. Now you've got a busy slide here, and I entitled this presentation Evidence from Australia's Medicinal Cannabis Natural Experiment. So it was a rollout of medicinal cannabis. There was no evidence to support its use. Prescribing is totally off-label. And I call this a natural experiment. And this is the type of data the OMOP community can work on. Data that's considered just a natural experiment, because it's often we're seeing the delivery of therapeutics that are not necessarily introduced to the market in the usual fashion with phase 1, phase 2, phase 3 trials. So let's look at the upper right corner of the slide, and you'll see my work is centred on pharmacovigilance. And in this, I focus on the capture of data that will tell me more about the effects and adverse events associated with medicinal cannabis use. This is where OMOP fits in. Let's just go to background. In 2016, medicinal cannabis was legalised in Australia. It enabled the provision of medicinal cannabis to patients following approval of a script by Australia's peak regulatory body, the drug regulatory body, the TGA, and that's like the FDA in America. With this change in legislation, the number of medicinal cannabis approvals rose exponentially. Son, can you just get those graphs up? These two graphs, which illustrate two different approval pathways, clearly show the extraordinary rise in medicinal cannabis following legislation that allowed this product to get on the market even though it was not approved. If you look at the data, I've done all the cumulative stats. I don't need to read them all out to you, but what I will tell you is this indicates that currently there are over 1.2 million prescriptions have been approved to well over 800,000 patients. And these prescriptions, this is first off prescriptions. This is not repeat prescriptions. So if we go back to the first slide, Song, just the busy one, given this, the need for pharmacovigilance is imperative. So when we did this work, we considered the best way to undertake pharmacovigilance was to set up a patient registry. However, this was not possible because the TGA, like the FDA, data was not granular enough, and the TGA did not collect patient identifiers. So there's no patient identifier at all. So to get a better understanding of medicinal use in community, we needed to capture data from other sources, and that's that middle green section, and such as the GP and physician voice, prescriber voice, perspectives from pharmacist dispensers, stakeholders, politicians. I looked at that TGA approval data, which is evident in those slides. We did electronic medical record analysis and reviews of social media data. And in our social media work, we looked at sort of natural language processing. Today, I'm giving you a snapshot of just two of our research outputs. On the left-hand side of the slide, you'll find GPs and physicians were uncertain about medicinal cannabis effect, and were also really concerned about adverse events. At the same time, they understood community views may not match their own. However, they all stated the need for more evidence was imperative. And this is where OMOT can help this situation and a collaboration with interested countries. In our analysis of the EMR data, and that's found in the middle section of the slide, we sought to ascertain how medicinal cannabis was recorded in the EMR. In this work, we identified in the patron primary care repository, and this is a space where Roger and I work. We work with patron data. 80 patients were found with a combined total of 170 prescriptions. Notice this work was done up to September 2020, and just remember that slide, all the prescribing has happened beyond this time. These records were found in the prescription table in the database. This indicates that data was entered as a patient prescription within a GP's local EMR. And what was written in there was a generic name, the formulation, the trade name, the route, and the dose. The reason for prescription was included in the tables, and you can see anxiety, multiple sclerosis, cancer, nausea, Crohn's disease. It's actually seen as a panacea for like hundreds of conditions. I've just done some, and Roger and I have just done a little bit more analysis, and we have found the number of medicinal cannabis patients is now closer to 800. And the number of prescriptions is well over 1,600. However, of course, if we want to undertake this natural experiment, we'd like a little bit more power. So we would love you guys to join us, and it would be great if we could increase the power with some collaborative work. The recent analysis that Roger and I have just done, we hope we will be publishing this research shortly. In summary, let's just go to the bottom right-hand corner, and these are really important points. We face many challenges in healthcare today with rising numbers of difficult to treat problems, including all those listed there: mental health, chronic pain, addiction, insomnia, and treatment-resistant conditions. We all know, all of us here today know, consumers are increasingly driving demand for new therapeutics, such as medicinal cannabis. This changes the paradigm through which evidence-based medicine is practiced. Greater consumer involvement in healthcare is valuable, but should not be at the cost of rigorous and reproducible approaches that underpin scientific methodologies. So the way forward, in my mind, is to integrate all the available real-world evidence, including digital health data, clinical trial results, consumer discourse, and provider and patient experience, to grow the knowledge and understanding of new and emerging therapeutics, which is going to evolve in time. So that's my presentation. Clearly, there's a problem here. It is a problem in Australia. I have all the phenotypes We have the queries ready to go. We are wondering if any of you here would like to collaborate and interrogate your data to see if there is any recording of medicinal cannabis in the EMRs, in the databases, in the repositories. And that's that. Thanks, Song. You can, actually do the next slide, if you don't mind. Have you got the next one? Next one. Okay. And so this is all the published research we've got to date. So over the past 2 years, we've done a lot of work in this space, and I'd love to have an OMOP publication up there. Okay, thanks. You can, yeah.
Oh, so I'll open up the floor for a question. Am I breaking up?
No, it's all good.
Okay, I'm gonna turn off my camera just in case. I am having a feeling that my machine might crash on me. So, Christine, the phenotypes and the codes that you currently have, are they in OMOP? Because you mentioned Patron, and I wasn't sure whether Patron is in OMOP or not. So
yeah, Patron is a database with raw data, but Roger has been involved in a project where all that data has been converted to OMOP.
Okay, great. Roger, you're speaking muted. Yeah.
Yeah, so we've got the concept sets in OMOP.
Yep.
Okay, so if someone would be interested to see if they are capturing any patients, you will readily be able to share a cohort or concept sets over so that they can check. Okay, great. So that's the first question I had. I think the second question I had, Christine, is, so you expressed that there's a concern from clinicians from Australia. Is the concern more around the efficacy of the medicinal cannabis, or is it around the safety of the drug?
Both. So as we all know, use of therapeutics off-label is problematic. So that is the effect. So the effect is not certain. Hence, you can assume that all conditions for which medicinal cannabis is used to treat, they're all off-label. So we do not have any certainty to what condition medicinal cannabis improves. However, there is evidence that it does improve, like Dravet syndrome, intractable fitting in children. There are reports of it being beneficial in certain types of pain, but it actually is being used quite a bit for mental health conditions, anxiety and depression. And there are signals that this actually is causing problems. In America, women are using medicinal cannabis for symptoms of pregnancy. Medicinal cannabis affects the DNA of cells, and it actually impacts on the growing brain of babies in utero. So this is problematic. So one, it is effect, but adverse events and problems due to overprescribing for conditions for which it is unsafe is also a problem. So we would be looking for signals that indicate, so it does cause, it ends up being agonistic for psychiatric conditions, and it also has drug interactions with clopidogrel. It actually causes bleeding, and it has some other like benign effects like dry eyes, reports of gastrointestinal effects, and agitation. So there are all this work that is on that slide. We've just done a systematic review of adverse effects, and they're basically the conditions. and amotivational syndrome, etc.
Thanks for that, Christine. One last question from my end, and then I'll let others chip in if they want. So, I'm a bit the thing that's a bit unclear to me right now, Christine, is are you trying to do a characterization study, or like, so
Yes.
translating this into the OHDSI/OMOP language, right? So, what are you trying to establish in this study? Do you have a protocol that maybe people can refer to, or maybe a synopsis, even if it's not at a protocol stage yet?
No, well, we haven't, because this is just highlighting interest. So the work that Roger and I are doing at the moment is we're characterising patients and characterising users.
Okay.
So basically, we are looking at the pharmaceuticals that they're on, so their concomitant medications. We're looking at past history, we're looking at current history, and we're looking at like gender, age. That will be the first part of the study. Then the second part of the work will be looking for temporal associations. For example, we could see if medicinal cannabis is in fact opioid sparing, or it ends up being benzo or SSRI sparing. So we would be interested to see if it actually has sparing effects for other therapeutics that treat mental health conditions or pain. And then we'd also like to use sophisticated methodologies to detect signals of adverse events. And the way we did it in this work that we've done on electronic medical records is we looked for a recording of a condition within 6 weeks of first administration of medicinal cannabis. And in that condition, that patient should not have had that condition in the medical record, the prior medical record. So, for example, if a patient had chronic pain and had no history of psychosis previous to this pain, and then commenced medicinal cannabis with a high level of THC, and then within 6 weeks, there was a recording in the EMR of psychosis, that could be a potential signal. That's the type of work.
Okay. So, Christine, just to summarize what...
Song, could I just make a point? Just to point out, this is our first network study, and your point about a synopsis is entirely correct. Would use something like Nicole's work that she did on MS, the Telemus project, as a template for that. So I think it would be good to have a synopsis, as you suggest. Yeah. So we can easily put that together. So
yeah, I think that would help a lot more. Sorry, Song's team has crashed, so yeah, I'm taking over for the time being. But yeah, I think that would help a lot more from I think the OHDSI community, because for a lot of the OHDSI folks, right, they have to look at what the actual use case is and whether or not they have to go back for IRBs and all that. But I actually had a question as well, because I was looking up. You know me, I don't have a background in medicine. So I was looking up what you guys are even talking about. Okay. Yeah. So I figured out it's basically medical marijuana. Okay.
Yes,
in my simple mind, that's what it is. Okay.
That's a beautiful thing. Yeah.
So in the US though, because I was actually thinking about that, what time period are you looking at? Because in the US, we have a lot of quite a few states where now the recreational marijuana is technically legal, right?
Yes.
So anybody can purchase it, so you don't have to go through the doctors anymore, right? So it's not gonna, if you were looking back, you know, probably 5-6 years ago, you probably will find that. But if you're looking more recently, you probably will see a lot less cases of it, because it's now just so. Now, also, the other side effect is, for a while there, they were prescribing it. And I can tell you from many cases, and you can find them in the news, right? A lot of people were actually getting it, but weren't using it. They were just, in California, Okay,
Correct.
so in California, 4 years ago, there was a law, because I live in California, there was a law that went through to say that people could legally grow marijuana for medical purposes.
Yeah.
Okay, so everybody went to the doctor and got that little prescription.
Yes, yes.
But guess what? They didn't use it. Okay, they ended up selling it. So I don't know if your data may be skewed that way. That's why I'm asking, right?
Yeah.
So that's the other thing. What are you looking for? And just to take into account like cases like California, if you actually have data from the United States, your research may be a little skewed because of the fact that you're going to see a spike in the last couple of years, whenever the heck that law went in place in California. And then you're going to see it gone because it's legal now here. Everybody can just go to these dispensaries and buy them.
Yeah. So it will be, what we are looking for is a record, like a record in the EMR that says there is a prescription of medicinal cannabis. And even if it's over the counter in a dispensary, I was in New York this last Christmas. Their dispensaries are all, I took so many photographs.
Dispensaries everywhere too, and you don't need a prescription. That's the thing.
No, you don't. However, it'd be interesting to see if patients report to their local family doctor, like you do. You're on zinc. You're on. They don't.
You trust us too much.
Yeah.
Oh, well, look, I'm being recorded here.
Well, the thing is, I know in South Korea, the context is fairly similar. So we may just have to get even the international community, say in Israel and in the UK and in other European states where medicinal cannabis is still only accessible.
Correct. So some of them, even in Europe, they are legal as well for recreational. Yeah. So that I was going to bring that up too, right? I mean, here in the U.S., it's only certain states they're legal for recreational, and you don't need to go to your doctor to tell them anything. You just, go buy.
In other states, there will be. So I
other
just
states
think
there will be, yes.
And this is why I just presented this one slide, because it's important to see if it is feasible in this community first. So I'm just literally giving you an appetizer, a little taste.
Roger, you've had your hand up and we've ignored you.
I'm just to reiterate, what you say is very good information, Mui.
Yeah.
We'd need somewhere with a similar regulatory environment to Australia, where it's prescribed, and there are jurisdictions around the world that have that environment.
Yeah.
Correct.
So I appreciate what's happened in California. What I would say, just thinking about this, there would be potentially records in the GP data about marijuana use. That could be associated with adverse effects. So we'd have to look through the medical notes of that, which would be a lot harder. Saying there could still be a signal there.
Well, I just think if you go back, right, but again, it was at one point in time a prescription. So if you go back in time, it's fine. That's why I'm just asking for you what your study period is, right? Because if you go further in time, like I think it was legal 2 or 3 years ago, right? Then you're gonna be skewed. That data is going to be skewed. Same thing when they put in the law to say anybody can grow them at home, and you don't actually have to go and get it dispensed anymore. Your numbers are going to be skewed, right? Because the number of prescriptions went up, skyrocketed like crazy when they said you can grow 90 plants at home.
Well, look, so that's an interesting experiment in itself. So what we would do is we'd look at the data, we'd map it with context, and we either put in caveats, we put in limitations, we take that data out because it has got confounders. So we just do this work like you do any biostatistical experiment, and you just say, look, we can't use that. However, that tells its own story. So you might publish your own little paper, you know.
Yeah, I just wanted to bring that up. You know,
it's a very good point.
It's very different.
Well, don't worry. I had my phone out the whole time taking photographs, and I was in New York sending it to Yvonne, my colleague. I said, look, what the hell is going on here?
I can take plenty of them. They're just right down the street.
Yeah, but there are equivalent states, absolutely. So,
yes. Where it is required, yes.
And particularly South Korea. Anyway. I think there's another hand there.
Song, you have your hand up again.
Yeah, sorry for crashing. I was just trying to understand then from a community standpoint, Christine, you're trying to get some people who might be interested in the study and see if they have any suitable patients in their database as of now.
Correct.
So, and moving forward, you would likely work with these people in order to come up with a study protocol and design your study, right? I know you said you have some initial work that you're doing with Roger, but I'm pretty sure this is more on the source data side, not the OMOP side, right? The existing work you've done. Or is it?
No, well, we've done some. We're going to publish a validation paper where we're matching the source data with the OMOP converted data. And it actually matches really well. It's quite interesting.
I'm talking more on the actual characterization study in which you're thinking of. Is it started, or would that be something you would need to do from an OMOP perspective, right? Not the source data perspective.
Like characterization, we have done some preliminary work on the characterization, but the final work is going to be done in the next month.
Okay. So I guess the ask to the community here is anybody that's interested and is willing to run a few counts to see if they have any suitable patients with the right regulatory situation as Australia, they would reach out to you and jump on board to see if there's any chance of working on the study together, right?
Yeah, and so what needs to be said is the counts will be relatively low compared to other prescriptions, or so you might need to do some mapping of your data if you choose to come on board.
Great.
Because of low counts.
Okay. Mukesh, Roger, both of you.
Oh, sorry, I should take mine down. No, I've asked my questions.
Yeah, actually, my question was building along Mui's point. I was wondering, have you done a survey where you've actually found countries where medicinal cannabis is legalized? So that could help you narrow down where your potential ㆍData partners are. Yeah.
Yes, we have. Yeah. And I can give a list of the countries: Israel, Czechoslovakia, the UK, there's a suite. Italy, there's a suite. A lot of them are in Europe.
Okay. Like in Singapore, it's not legalized yet. So that was where I was thinking, maybe perhaps in your protocol, it might be good to have that listed somewhere.
Singapore is not legalized. So is there any usage there, do you think, of medicinal cannabis? Is a product out there? Medicinal.
Right, very rare. To my knowledge, I think only 2 or 3 patients thus far on very rare scenarios have been administered such a drug. But otherwise, I think the legalization is the issue right now. It's not yet legalized. Yeah.
Well, South Korea is in exactly the same position as us at the moment.
Okay.
So, and there's a lot of power in that data set, but I welcome others. And we can roll it out, we're the Asian community and Asian Pacific. We can roll it out across to other countries, other communities, once we get our protocol.
All right.
This is just I'm just trying to gather interest because it's novel.
Yeah, it is. Any more questions? The community.
Thanks for listening, everyone. I appreciate it. Thanks for putting it on the agenda too, Song.
No problem at all.
Thank
you.
Interesting, very interesting study.
I agree. I'm passionate about it. Not passionate about the product. I've never taken it, but okay. Thanks, Mukesh. Thanks for your lovely warm smile there. I can see you ready to move on.
Okay. All right. Thanks.
Okay.
We'll move on to Chungsoo next. Give us an update on the data quality studies that's been working on. So over to you, Chungsoo.
Okay. I share my screen. So you guys can watch my screen now, right?
Yes.
Yeah, you can see it.
Okay. Yeah. Thank you for having me today. I'm Chungsoo, my PhD candidate in biomedical informatics at Aju University, South Korea. I'd like to share about two different studies actually. First one is some updates in our previous APAC data quality study conducted last year. And the second one is another opportunity for new network study. Before talking about the updates of this quality study, I would like to briefly remind about our study. Our study objectives are very simple, and what is this study for? Collecting CDM inspection reports from APAC region. And why is this study needed? And to check the current status of CDMs in APAC region and get insights from the CDMs and seek quality improvement points. And methods were also very simple, and we collected CDM inspection reports from the data partners of APAC community, and in the report there were many collectibles such below. Briefly, we collected the summaries of data and the mapping information for quality results of Achilles heels and information on infrastructures. So we got a new report from the NUS team, and thank you, Easy and Morning. And now we closed our study for additional data partners, unfortunately, and we requested some inquiries to data partners about missing data or some issues. Like, for example, we found that some data partners had excessive number in their visit source value column. And after discussion, we figured out they store things like widget ID rather than the widget type, which is not exactly in line with the current CDM 5.3 convention, but maybe met their needs. And yeah, we requested some inquiries like that, and we are still in writing the draft of manuscript, and maybe we can share the final draft in a month. But before that, you can find our draft manuscript in our Teams channel. If you are interested in the review or having any comments, please comment in there. And lastly, we made a poster for the annual symposium of the American Medical Informatics Association. Yeah, happy to share our poster in here, and this poster will be presented in 2023 AMIA at New Orleans next week. So please review this poster, and this poster is also in the Teams channel, and check your application for sure. And if you have any comments for this, please let me know in this week. And yeah, this was very brief and high level updates for this study. And yeah, I'd like to jump right into the next study, and this is for advertising our current another network study. As you can see in the title, this study is about developing a deep learning model using AMOP common data model. We are trying to compare conventional prediction method with more complex deep learning methods. So we entitled this study Deep Learning Comparison, a Odyssey Network Study. I'm working on this study with Henrik and Egg in Erasmus Medical Center and Jenna in Janssen. And this slide was presented in 2023 ARIS European Symposium also. So we found that the most commonly used group of prediction method in healthcare data, especially for the structured data like EHR or claims data, is regression. This is in contrast to other areas such as, self-driving cars or medical imaging analysis, where deep learning methods are most widely used. Observational healthcare data was found to limit the performance of the deep learning methods due to their high sparsity, high dimensionality, and heterogeneity. So we designed a systematic comparison of deep learning methods and conventional prediction methods using observational healthcare data formatted to the AMA. So we set some benchmark prediction problems, which were already published in our previous prediction papers. And we configured our development setting, including conventional and deep learning algorithms. And we have some confirmed databases now, but we are still recruiting some other countries' databases for training our models and packages. This is our preliminary results presented last European Symposium, and the logistic regression still shown high performance than the deep learning algorithms, but we are hope to validate this result more with other databases also. So we have a GitHub repo which has detailed study protocol, and we also release our study package to Docker Hub, which has Docker image for easily adapting the package requirement to your environment. And if you are quite familiar with the Docker, you can run the study for testing at this moment. And yeah, even this study actually requires a GPU hardware for deep learning models. But if you have any interest for our study, please feel free to get in touch with our team, me or Jenna or handling. You can please feel free to get in touch with us. Yeah, thank you. Do you have any question? Anyone have a question? Hey,
Hey, Chungsoo.
Yeah.
Yeah. Okay. Thank you for your sharing about the data quality assessment and the deep learning prediction. I'm quite interested about the deep learning prediction because we are about to working on the to predict the incidence of the dementia among the patient who have a kind of the diabetes,
okay,
or like heart disease. So my question is like for your prediction more problems of the dementia, that is the outcome, or like you predict the incidence of the dementia of dementia among the general population.
Yeah, that is true. We are trying to predict the dementia in the people aged over 55. So that means the general population in our database.
Oh yeah, great. Yeah, so maybe I will set up like our study. Like we wanna do the prediction model among the metabolic syndrome patient. So yeah. So like maybe like I also like want to invite to go for the collaboration if you are interested in that. I can share my protocol
okay.
to our community. Yes.
Yeah, great.
Great. Thank you.
So actually, I heard from Jenna. Jenna met someone from the, I think, TMU. So so I heard that they had some interest for this study. So So not only TMU, but you guys have any questions or interest, please let me know, and I think we can discuss for your participation to this study.
Yeah, we will need to participate. That's very interesting. Yeah. Thank you, Chungsoo.
Chungsoo, Phuc is actually from TMU, by the way. So,
yeah.
Sorry.
So,
Yes.
You guys are having the meeting right now.
But Jenna probably met Jason.
Oh, yeah. Okay.
Yeah. That's great.
Yeah, Jenna
so we have a
probably
common
met
bond.
Jason from
Yes, we have a common bond and common interesting.
Chungsoo, I have a technical question, right? So you're saying you're predicting dementia in people aged over 55, and it's in the general population, right? How do you define that in Atlas? Any condition, or like how do you define the general population?
Maybe I think we can define the general population with any visit records, but
visit. Okay, you're using the visit table. Okay.
Yeah, but I have to check our Atlas definition.
Okay. Because it's either any condition or any visit or like any drug or like that, right? Because Atlas doesn't allow you to choose the entire population, true. Right? Unless you do it in SQL, right? So I was just wondering from a technical perspective. Yeah, interesting. I have no further questions. Mukesh, over to you.
Thanks. I had one question around the prediction method, actually. But it's okay. There was a part where you mentioned gradient boosting, right? Are you actually looking into specifics like XGBoost, like gradient boosting, or it's a classical gradient boosting algorithm?
Sorry, could you please repeat again?
Oh, I was asking, like, is there a specific gradient boosting algorithm that you're using for your example here, like XGBoost, light gradient boosting, cat boost?
We used XGBoost at first, but we also have some we also implemented the right GBM in our patient level prediction framework, so we can use them also.
Okay.
So in summary, Chungsoo, you're just using the patient level prediction models available within the OHDSI community, right? The ones we are using. Okay.
Yeah, so the deep learning algorithm is also implemented in the OHDSI framework with the deep patient level prediction framework. So so if you are not familiar with, but we also made a Docker image for easily adapting to your environment. So maybe you can just type a line, so then the study package will run with your databases. Thank you.
Thank you.
Mukesh, I'll share my screen. I hope I don't crash again, but let's try again. Okay. Here we go. There you go.
All right. Yeah, we can see the slides. Great. Yeah. So in the previous call, we had Anna who kindly joined us and shared about the vocabularies, in particular about the templates, right? How can we use the templates to actually expand like addition of non-standard terms and perhaps even converting some of those non-standard terms to standard terms. So she's coming back again in December to share with us more in terms of the drug vocabulary here. The previous session was more focused on the non-drug vocabularies. So here is going to be more focused on the drug vocab areas because there were some interest and questions from the community. So again, do join us to find out more about how we can actually work with the OHDSI vocabulary team in meeting your needs for your studies there. All right, and the recordings are actually available online for the previous session, so do check them out if you want to find out more about what was covered in the previous sessions. Now, coming to the follow-up survey, you'll have got emails regarding the areas of support. And we've extended it. We want more responses. Right now, I think we've got about 10 responses. So it'd be really encouraging if we could have perhaps all of us here at this call actually doing this survey. So that will help us get more understanding in terms of where we need to focus next year's APAC Scientific Forum and what topics are the ones which we're focusing on. So that will benefit us directly. Right. So do support us in doing this survey. We've extended it till the end of November. The link is there. We might send out another email just to update the community about extension of the survey. All right. Yeah. We're good there.
I guess I want a bit more emphasis here, right, guys? The vocabulary sessions we're having with Anna is because you guys spoke out, right? Because you guys asked for such sessions. So if we want to have more of these sessions, we really need your voice. So please do participate in the survey so that we can get some topics planned out for next year, right? Instead of us trying to chase the same old people over and over again on a monthly basis. It would be nice to have some refreshing topics, or even having sessions where we answer questions that people assume everybody knows, but it's generally that's not the case, right? So please do participate in the survey. We will send out a reminder again so that you have time to fill out until the end of November. Okay, I think we've got everything right. Okay, let me stop sharing and we can close out the call. Yeah,
before we
that's all we have for.
Okay, so before we close out the call, I don't think Nicole is here. She's not here, right? So I want to say congratulations, and we'll do this again on our community call. And Sung's already giving me that look. Congratulations to our 2 Titan Award winners from the symposium. Okay, there are only a total of 8 Titan Award winners, okay, and that's through the entire community of however many people. We had 2 of them from Asia Pacific this year, okay. That's 25%. That's amazing. So it was Nicole for community leadership, and then Sung for community support. So I want to say thank you, one, for Sung for supporting us as a community with all the work that you do. There's a lot of stuff that he does behind the scene that most of us don't see, right? And like all the symposium, APAC symposium plannings and all these calls, right? So thank you. Congratulations there. Nicole's not here. We're going to embarrass her on the community call next.
And I echo that, Mui, because Song, you've been great. You've touched base again, and every time I've asked you a question, you give me details, and you're always responsive. And no, you deserve it. You really do, because it's So next symposium, we'll have a glass of champagne. Are we allowed to say
in
that?
Singapore, Morning's still here, right? Morning might have left. I heard at the symposium, it was recorded that he's going to buy everybody drinks. Okay?
No.
That's what he said at the annual symposium, at the global symposium. He said, if you come into Singapore, he's going to buy you drinks at the top of the boat. Okay? Mikesh, you heard that. We all heard that. So
I welcome that.
Make sure 2024 you go to the APAC symposium in Singapore, because Morning's going to be broke after that.
Well, the Wonka symposium's in Singapore as well next year. I'll have 2 trips to Singapore.
Say?
What month is it, Christine?
The Wonka in November, I think.
Oh, see, they're right next to each other. This one's December 6th through the 9th.
Oh, is it really?
Yes.
Maybe extend your stay.
Hey, do you have a Sofitel there, Mikesh? I'm a Sofitel club member.
Okay, all right.
I've got some free points. I've got lots of points.
Yeah, so do join us.
We have another point gatherer here. So Mui and Christine, you guys could chat.
Right? I stay at Hyatt, so
I know. I'm at the Sofitel, and I've got like so many weeks of points. Because I've linked it to my airline. I've linked it to.
I went to Spain for three weeks, all on points.
Wow.
I know. I think you told me. Hey,
Yes.
Mui, you're my points inspiration.
All right. We're good there. Okay, with that, we can end it. But I just wanted to put that out there so that Song doesn't realize that I was going to embarrass him, you know.
Oh.
At least I did it at the end of the meeting and not the beginning of the meeting, because then his face would stay red the whole time. So
You're
once
a
again,
good
congratulations.
person. Yeah.
Thank
And
you for
Nicole's
the
wonderful.
guys. Yeah.
Yes. Thank you, everybody.
Okay.
Bye
Okay.
now.
Bye everyone.
Back
See
to
you
bed.
next month.
Bye.
Ciao.
Bye bye.
Bye.
Bye bye. See you.